You might have seen a small name and lot of degrees. That was my dream when I was a medical student. What the teachers or the person who wrote the book used to have such kind of degrees. MBBS, MRCP, FRCP, London, Edinburgh and Glasgow. I was imagining one day I will also get it. But it was a long journey, but I got it. And I hope some of you also take the path. Today I am wearing a tie which looks very ordinary. To wear this tie, you have to sweat. This Royal College tie, only members of Royal College are given this tie. And you are supposed to wear when you speak in public auditoriums or when you go to the court. Because judge will recognize you. Oh, you are a member of Royal College of Physicians. Like that. So today I will be presenting to you a case of... Pardon?
It is only for physicians, Royal College of Physicians, because the gynecologists don't have it.
I don't know. Because gynecologists, they don't wear the tie. Probably there is something else.
Nowadays the dress code has changed. They might wear the tie also.
Today I will be presenting a case which we had treated in this hospital, that is scrub typhus. Most of you have seen it, but some physical signs you might have not seen. That is the reason I am presenting, and that is the reason I put a heading as ESCHAR, not ESCHAR, it is ESCHAR. This is the most important clinical sign in the treatment of scrub typhus. This is the diagnostic of scrub typhus. First I will give you some questions just to stimulate your brain. Followed by I will present the case which I have treated. Then followed by some theoretical aspect of scrub typhus. Scrub typhus is caused by virus, mycobacterium, gram-positive bacterium, gram-negative bacterium or fungus. You can note down either in the paper or in your mind. And at the end of the lecture, we will discuss what is the correct answer. I think you already know the answer. Scrub typhus is caused by Rickettsia sugusugumushi, not the T is silent there, sugusugumushi, Rickettsia prowazaki, Rickettsia japonicum. Scrub typhus is transmitted to human by Leptotrombidium mite, rat, Leptotrombidium adult. Mite is in a larval stage, adult is an adult. Aedes aegypti, or it is transmitted to human. What are the other diseases cause ESCHAR at the site of infection? One is scrub typhus, we know. Eczema gangrenosum, rickettsial pus, anthrax, all the above. Drugs used specifically to treat scrub typhus are, except doxycycline, azithromycin, chloramphenicol, meropenem. What are the poor prognostic indicators of scrub typhus? Elderly people of more than 60 years age, those with high initial white cell count, those with high initial CRP, those with high liver enzymes, those who presented without ESCHAR, all the above. Now I will go to the case which we treated in this hospital. Mr. KVS and Raju, a male patient, 54 years age, was admitted on 24/7/2023 to our Queen's NRA hospital with history of a fever with chills on and off for the last 8 days. And also he noticed an ulcer on the left thigh with erythema surrounding the ulcer. He vaguely remembered being bitten by an insect at his friend's agriculture farm 10 days ago while having a party openly. This is the lesion which he had on the left thigh. There is erythema, there is an ulcer, there is a crusting. This is called ESCHAR. He developed erythematous maculopapular rash all over the body on the day of admission. Actually, this has driven him to the hospital. He has been a diabetic for the last 20 years on Novamix insulin 30/70 25 units in the morning and 25 units at night. He took augmentin 625 milligrams twice a day for initial 2 days. He stopped after 2 days as he developed loose motions and abdominal discomfort. He started cefuroxime 500 mg BD 2 days before admission. On examination, he was febrile. He is having temperature around 101. His pulse rate is high, 101. And BP 130/80 normal. Lungs were clear. Cardiovascular system did not reveal any abnormality. Heart sounds are normal, but he is tachycardic. Abdomen mild distended. Bowel sounds are normal. He is conscious but a bit irritable. Lab reports: WBC 7000, hemoglobin is 14 grams, CRP is high 23 milligrams, 23.71. Peripheral smear was normal. LDH in the upper limit. Urine microscopy there 6 to 8 pus cells. Dengue serology was negative. Malaria, typhoid were negative. HBsAg, HCV, HIV were negative. IgM scrub typhus was positive. Ultrasound abdomen, he has got a cholelithiasis. Chest X-ray was absolutely normal. ECG was normal. Urine culture, there was no growth, and blood culture, there was no growth. Patient was started in Cefepime 1 gram IV BD and doxycycline 1 gram IV BD. Patient had high grade spiky fevers for 3 days, and third day fever subsided suddenly, lysed on the third day. And ulcer on the thigh was healed by 5th day, and rash over the body disappeared gradually over 2 days. You can see the temperature chart, very high spiky fevers for 3 days, and a third day suddenly stopped and became normal temperature. This is the sign of successful treatment of scrub typhus. If a patient you suspect a scrub typhus, you started on doxycycline, if third day, fourth day fever has not subsided, please think of other diagnosis. It may not be scrub typhus. That specific is the response to doxycycline. If rare possibility is he has got a resistant, the strain scrub typhus is resistant to doxycycline. But in India, 99% that is not a scrub typhus. His fever doesn't subside by third day. He was discharged to take doxycycline 100 mg BD for 10 days. This is the type mistake. Azithromycin 500 mg OD for 5 days. After 10 days at the review, he was healthy and ulcer healed completely. So now I will tell some of the theoretical aspects of scrub typhus. Scrub typhus is an acute febrile infectious illness that was first described by Chinese in 313 AD. It is caused by rickettsia. Nowadays we call it orienta, but earlier it was classified in the rickettsia sugu mushi. The meaning of sugu mushi means bad health, ill health. Mushi means mite. The disease caused by mite. It's an obligate intracellular gram-negative bacterium. You have answered for one of the questions before, which was first isolated in Japan 1930. Although scrub typhus was originally recognized as one of the tropical rickettsial disease, sugu mushi differs from other rickettsia with respect to cell wall and genetic material. So they called in a separate class now orienta sugu mushi. It was earlier rickettsia sugu mushi. The name of the scrub typhus derives from the type of the vegetations where it habitate. This is called forest or woods. These are the clearings. Forest and the plain area. In between, this is called scrub. This is the place where this mite lives. So it is called scrub typhus. Between the forest and the plain land. Sugu mushi, the pathogen that causes scrub typhus, is transmitted to human through bite of an infected chigger. Chigger is a larval stage of Leptotrombium mite. This is the larval stage of the Leptotrombium mite. Usually it has got 6 legs. Adult will have 8 legs. These 6-legged 0.2 millimeters, very small, teeny, very small. It's difficult to find when it is in the cloths. 0.2 millimeter larvae are not host specific. They live on all other animals, and they usually suck the skin fluids. They live 2 to 10 years, and they become 2 to 10 months, days, and they become adults at that stage. So once they become adult, they live on the sand, they won't bite. So these mites are the responsible for the disease, and they are very small and tiny, and they usually live on wild animals, and usually wild rats are the host. Though they nature the disease, they never have the disease. They only transmit the disease to humans. So when this mite bites a wild rat and later on it bites a human, you get the infection. The another funny thing about this sugu mishi is it is transmitted transorally from female by a mite to children. So once sugu muchi infects the mite, it tries to produce more females than the male. This is something abnormal in the nature. So once it is sugu infects a mite, the mite is likely to give a more female children because so that it can transmit the disease through the ovaries. When chiggers feed on the humans, then the infection occurs. While taking the history, the points to note are: did he travel to an endemic area? Did he visit a open place or scrub? Is there any history of insect bite? Unless you prove, usually this history will not be given. The incubation period is between 6 to 20 days, roughly 10 days is the average. Usually they present with headache, shaking, chills and fever, conjunctivitis, lymphadenopathy, loss of appetite, anorexia, restlessness. There will be a small area of increasing painless papule with central necrosis followed by ESCHAR formation. This is I am again projecting another slide. This is from the textbook. Classical ESCHAR. So what are the physical signs we have to look for? Infection at the site of a chigger bite, that is ESCHAR formation. Patient usually have very high fever, 104 to 105 degrees, occurring almost 98% of the people who have high grade fevers. And tender regional or generalized lymphadenopathy, between 40 to 90% people will have either local lymphadenopathy at the site of ESCHAR or sometimes generalized lymphadenopathy. Rest frequently they can have ocular pain, wet cough. But in Indian people, they usually present with cough and pneumonia. What I found is, most of the scrub typhus found in my practice in India, most of them they have respiratory symptoms and fever. They have a patchy pneumonia also. And conjunctival injection, erythema are common. The centrifugal macular rash on the trunk usually appears 5th to 8th day. This is the centrifugal classical rash from the textbook. But our patient has only papular rash that usually occurs between 5th and 8th day. Our patient has a rash on 8th day. The purpose of the lecture is to demonstrate these two: ESCHAR formation and rash. And patients also can have a splenomegaly and can have a pneumonitis, encephalitis, cardiac involvement in the form of myocarditis and cardiac arrhythmias. And another interesting story which I didn't come across, but with a patient with fever, presents with acute hearing loss, is most likely to have a scrub typhus. There are reports that up to 30% of the cases they lose hearing temporarily, but they recover. Rarely, acute renal failure, the patient may go to renal failure, shock, DIC, and sometimes they may die. What are the diagnostic tests available? There are plenty of diagnostic tests available. That's what is available in our hospital is rapid immunochromatograph test for detection of IgM and IgG. This is what we do. And indirect fluorescent antibody test is sensitive, but it's not available in Visakhapatnam. Probably you have to send it to Bombay. Indirect immunoperoxidase test and immunofluorescent test. This is for academic purpose. This is usually done in endemic areas when you do research. Fourfold rise of a titer of antibody during fever and during convalescent phase to confirm the diagnosis of dengue, because most of the people in endemic area, they are already positive for IgM. So to recognize that whether they had an acute infection or not, they use this test. This is mainly theoretical purpose. You can also send a specimen from the ESCHAR which gives a positive PCR report. You can identify sugu mushi by PCR test if you send the biopsy of the ESCHAR. but it should be done in the first few days, let us say 1 week, first 1 week of the infection. After that, the bacteria disappear. Wheel Felix test is a very interesting test. When we are microbiology students, we have to by heart various types of reactions to Wheel Felix, and they usually ask in microbiology viva. But now this test is not done, and it became absolute. And if you take a histology, then biopsy, you may get a vasculitis. So what are the other investigations? Initial stage, there may be lymphopenia, but as the disease progresses, they get a lymphocytosis. Thrombocytopenia is common, elevated transaminases, and elevated CRP. These are the physical findings, laboratory findings we may get in scrub typhus. What are the diseases that you should differentiate between scrub typhus? Leptospirosis is a closed condenser. This also acquired while you walk in a dirty water. They can have jaundice, elevated enzymes, high fever, renal failure. They do not have ESCHAR. They can also have rash. Dengue fever also closely remember. They have high fevers and thrombocytopenia, abnormal liver enzymes. But dengue fever, they will have a more body pains, back pain, headache, body pain. That is not the feature of scrub typhus. Malaria can easily identify the spear exam. They can have fever, high fever, chills, thrombocytopenia, abnormal liver enzymes. They all may resemble, but laboratory tests usually differentiate. Typhoid also can mimic, and viral fevers. There are many other viral fevers other than dengue. They closely resemble our scrub typhus. They can have fever, thrombocytopenia, and skin rash. All features are common. Anthrax with ulcer and lymphadenopathy and high-grade fevers resembles scrub typhus. Other rickettsial fevers like rickettsia pox, they will have a ulcer and lymphadenopathy and high-grade fever. There are some viral hemorrhagic fevers with renal failure that usually occur in forests. This also resembles scrub typhus, but we have the means of differentiating. As a treatment, very simple, doxycycline 100 milligrams 2 times a day for 10 to 14 days. The longer the better, because there is a possibility of relapse. Usually, I think 2 weeks is the better time rather than stopping it at 1 week. Those people who cannot take doxycycline or allergic to doxycycline, or if they are pregnant, azithromycin is an alternative. If you suspect resistance to doxycycline, azithromycin, rifampin and chloromycin or the other drugs can be used. Scrub typhus, if you diagnose and treat, very simple. But scrub typhus patients who are not treated may develop severe complications and may die. Mortality rates ranges from 1 to 60, depends on the location of the patient and the strain. So it can be as low as 1, as high as 60% mortality rate. Death may be due to either primary scrub typhus or patient have pneumonitis followed by ARDS or DAC or circulatory failure, renal failure, encephalitis. Patients can also have encephalitis, seizures and coma. Elderly people of more than 60 years of age with initial high leukocyte count, with initial high CRP, with high liver enzymes, and those who presented without ESCHAR are more likely to be serious and get into complications. The who presented without ESCHAR, the reason is failure to diagnose early. Because unless it is there, we think some other viral fever and probably we don't start a specific drug. This also answer to one of the questions earlier. What are the preventive measures we can take? Protective clothing. When you go to the forest and when you go to the scrubs and forests like that, try to wear a full pant and full hand shirt. When you go for tours, I will always go to full hands and full hand to the forest area, and one of my colleagues asked me, why do you wear full hand and full shirt? When you go to the town, you come with half pant and t-shirt. I didn't say answer. Next day we went to the party, one mosquito has bitten him. Then he came and told me, no, why you are wearing, I know that. So avoid sitting on the soil. In the forest area, never sits directly on the soil. You may likely to be bitten by a mite. So always use a cloth or a carpet and sit on that. When you go for parties, don't sit on the soil. Spread a carpet. You can use insect repellents to prevent bites. Vector reduction and environmental measures are done by SPM people. So there is a chromoprophylaxis. A single dose of doxycycline given every week starting before going to the place until 6 weeks after coming from there. It's like a malarial prophylaxis. You can give a doxycycline if you suspect scrub typhus is very common. Usually Vietnam, Cambodia, these things are Japan is very common. A single oral dose of chloramphenicol and tetracycline given every 5 days, total for 30 days. This is another alternative. There is no vaccine available for scrub typhus. So while preparing these slides, I found something interesting. Those HIV patients with high viral count, if they get a scrub typhus, the count comes down drastically. So the immunity acquired for a scrub typhus kills the HIV virus. This is under investigation. This is a very interesting point. The counts comes drastically too low once they have a scrub typhus. The other point I forgot to tell, the scrub typhus very common in a triangular area from Japan, southern Russia, Afghanistan, Pakistan, south to Australia. This is called triangle. Scrub typhus triangle. This is the area where most of the people live. They say it's 50% of the human population live in this area. And this is very common in the scrub typhus. In India also, northern India is very common than the south India.
How common is this? What's the incidence?
In India, less than 1 in 1 lakh. Not so common. But it comes in epidemics. Thank you very much.